difficult to get connected.
மேடம் இப்போ அந்த கிரீன் இது மேல நம்ம லெஃப்ட் டாப் பாத்தீங்கன்னா லைவ் ஆன் யூடியூப் வருது பாருங்களேன்.
ஆமா.
இப்போ அதுல ஒரு டவுன் ஆரோ வாட் இருக்கு பாருங்க. அத பிரஸ் பண்ணீங்கன்னா காப்பி ஸ்ட்ரீமிங் லிங்க் வருதா?
Speaking is now live streaming on tube ன்னு வருது. காப்பி ஸ்கிரீனிங் லிங்க் ன்னு வருது.
அத நீங்க பிரஸ் பண்ணிட்டீங்கன்னா நீங்க அத ஒரு தடவை பிரஸ் பண்ணி பாருங்க.
பிரஸ் பண்ணிட்டேன்.
இப்போ chat box
link has been copied to the clipboard.
ஆமா chat box வாங்க. chat box வந்துட்டு
இதோ வரேன்.
chat boxல ஒரு சும்மா ஒரு தடவை அந்த மவுஸை டச் பண்ணுங்க.
ஒரு சுத்துறது வரேன்.
அங்க வந்துட்டு chat box-ஐ கிளிக் பண்ணிட்டு கண்ட்ரோல் V போடுங்களேன். CTRL னு ஒரு பட்டன் இருக்கு பாருங்க.
ஆமா கண்ட்ரோல் வந்துடுதே.
ஆமா அவ்வளவுதான். இப்போ என்டர் போடுங்க.
எஸ்
அவ்வளவுதான் மேட்டர். இவ்வளவு சிம்பிள் தான் அது.
ஓ எஸ் இது தெரிஞ்சிருந்தா காத்தால கூட போட்டுருப்பேன் அப்படி.
நோ ப்ராப்ளம். சார் ராவ் சார் குட் ஆஃப்டர்நூன்.
குட் ஆஃப்டர்நூன் சார். குட் ராவ்.
எல்லாம் உள்ள வராங்க சார்.
Good afternoon everybody.
Good afternoon madam.
Good afternoon. My God, what a rain it was.
3 மணில உட்கார்ந்துட்டேன். உங்களுக்கு ஒண்ணும் கஷ்டம் இல்ல.
எனக்கு ஒண்ணும் கஷ்டம் இல்ல. But the amount of struggle, my God, people have gone through. Didn't go out at all.
வாசல்ல எல்லாம் ஒரே தண்ணியா.
தேவாஜிரா
வாசல்ல எல்லாம் ஒரே ரொம்ப தண்ணியா.
போட்ல போனாரா?
அவர் வெளியிலேயே வரலையே. அவாத்துல எல்லாம் வரல. அவாத்து வெளியில தான். ரோட்ல தான்.
வந்த வழியில நிறைய indented. But generally Mylapore area is much better compared to other areas.
மேடம் நீங்க ஒரு ரெக்கார்டிங் போட்டு பாத்துருங்க மேடம் ஆகுதா?
நான் போட்டுறதோ ரெக்கார்ட் போட்டுறேன். ரெக்கார்ட் on this computer. Yeah, record.
2015 terrible experience. I was in that our independent house. I had to literally swim and come out. Water entered the house and all that.
Right, sir. Recording.
Thank you, madam.
Thank you.
Yes, madam.
Hi, Vidya. Welcome.
Hello.
Madam.
Hello.
My daughter-in-law, sir. My daughter-in-law.
I think அங்க நங்கநல்லூர்ல மீட் பண்ணுமா இவங்கள?
இல்ல அது வந்து இன்னொரு டாக்டர்-in-law, சிஸ்டர் டாக்டர்-in-law. அது இவ வந்து நாராயண்ஸ் கசின் பிரதர்ஸ் டாக்டர்-in-law. எங்க நாங்க எல்லாரும் அந்த வீட்டுக்கு போனவா தான்.
Okay. Nice.
He's an associate professor neurosurgery in GH.
Oh, fantastic.
He was in Sampath Kumarikella ரொம்ப நாளா தெரியும் because she was in Chengalpet for some time.
Madam, MS எந்த வருஷம் மேடம் நீங்க?
நான் டைரக்ட் MCH சார்.
5 years course தானா? 6 years.
5 years அப்ப 5 years 2005 to 2010 சார்.
நான் முடிச்சு வெளிய வந்துட்டேன் மேம். 2003 like came out of MNC.
ஓகே சார்.
அப்ப வந்து சுரேஷ் பாபு சார் ருக்மாங்கதன் சார்லாம் இருந்தாங்களா மேடம் அப்போ?
சுரேஷ் பாபு சார் வந்து 2006ல VRS கொடுத்துட்டு போனாங்க சார்.
ஓகே 1 year மட்டும் உங்களுக்கு இருந்துப்பாங்க.
1 year இருந்தாரு சார்.
வெல்கம் முத்துசாமி சார்.
Very nice madam. Nice meeting you.
Suresh Babu, his wife Sharada, I'm very good friend. They are from Madurai. My 1 year senior.
ரெண்டு பேரும் best outgoing madam அவங்க batch.
Best outgoing. I know. They love man everything. They were just 1 year senior to me.
நீங்க மதுரையா மேம்?
Madurai.
எனக்கு போத்தமா Madurai. Isabel sir. Sir was in Isabel's for a long time.
அப்புறம் தான் அப்போலோ போயிட்டு சிம்ஸ் போயிட்டு.
அவளை வந்து மேடம் வந்து ICHல தெரியும்.
Yes madam.
She was director of ICH.
ICH also. நான் வந்ததுக்கு அப்புறம் தான் ICH டைரக்டர் ஆனா, but she was there doing the MD, her MD எல்லாம் அப்ப பண்ணிருந்தா.
Were really both of them outstanding students for the subject.
Who is this Appo A15? Appo, yes sir, welcome sir.
Good afternoon sir.
Good afternoon sir.
Good afternoon sir.
See you.
Dr. Rao sir, you are ரொம்ப குவைட்டா போயிட்டேன். sir, welcome.
Retired from finance secretary post, nala quite a bit. When he was holding the post, he had authority. Listen, it was nice working with him. Get that.
என்னன்னா கேள்வி கேக்குறாரு நிறைய.
இல்ல ரொம்ப ரெலவெண்டா இருக்கும். To the point. Require such people. Organization to run.
மேடம் சென்னை மெயில்ல இதெல்லாம் முடிச்சா ரெயின்லாம் ஃப்ரீயா இருக்கீங்களா?
திருப்பி வருதுன்னு சொல்லிட்டு இருக்கா தெரியல.
ஆமா.
21st
Another depression.
மண்டேல இருந்து திரும்ப ஆரம்பிக்கிறதுங்க சார்.
நியர் அந்தமான் இருக்குங்கறாங்க.
ஆமாங்க.
ஃபேஸ் லைட் ஆக மாட்டேங்குது.
21st அன்னைக்கு விமன் டாக்டர்ஸ் நீங்க என்ன பண்ண போறோம்னு தெரியல இவ்வளவு மழையில.
அதான் அங்க ஸ்பாட் ரெஜிஸ்ட்ரேஷன் தான் பண்ணிக்கணும். Depending on the situation.
No spot registration. அது ரெஜிஸ்ட்ரேஷனே கிடையாது. வரலாம். Tell the count. சாப்பாடு போடணும்ல.
பேமெண்ட்ல ஒண்ணும் இல்லையா?
You can register if you want to come, you can come.
Yeah, I want to come, but I hope இந்த தட்பவெட்ப நிலையில அதெல்லாம் கொஞ்சம் சரியா இருந்தாருன்னா வந்துடலாம். நோ ப்ராப்ளம். உமன் டாக்டர் நம்மளே போலாம்.
ரெண்டு பேரும் ஒண்ணா சேர்ந்து போலாம்.
சரி, நம்ம ரெண்டு பேரும் சேர்ந்து போயிடலாம்.
நம்ம பிரசிடென்ட்ட காணவில்லையே.
கிரீஸ்வரி ஹாஸ்பிட்டல் முன்னாலாம் தண்ணி இல்லையே மங்கை.
வாட்டர் லாகிங் இருக்கு மேம்.
இருக்கா?
இருக்கு. இப்பதான் ரெக்ரெசிங்.
என்ன சொல்றேன்? இது உடச்சிராதாமா? என் மூவி அவன் பாக்குறான். ஸ்கிரீன் ஷாட்ல நான் இப்படி சின்னப்பா இருக்கேன்டா. அது ஏன் தெரியல.
நீ நார்மலா
எனக்கு வரலையே எப்படி பாக்குறேன் இதனால சின்னப்பா தான் இருப்பேன். அப்புறம் பின்னாடி போயிடும். ஓகேவா? ரொம்ப லைட் இருக்கா?
Good afternoon to everyone.
Good afternoon, ma'am. Make sure we meet often. நிறைய ப்ரோக்ராம் வச்சுட்டே இருந்தா இப்ப
எனக்கு எப்படி ஸ்கிரீன்ஷாட் சொல்லி கொஞ்சம் போயிடு. இப்ப மாத்தலாம் அப்புறம் மாத்தலாமா?
தெரியும். அதுதான்
மாத்த முடியுமா? சரி, எனக்கு ஸ்கிரீன் ஷேரிங் வந்து ஓபன் பண்ணணும்.
Hello. Good afternoon.
Good afternoon, sir, to everyone.
Good afternoon. உண்ட மயக்கம் தொண்டருக்கும் உண்டு எல்லாருக்கும்.
Vivian sir, good afternoon.
Good afternoon, sir. How are you?
Fine, fine.
Very busy. I understand you are very busy from the WhatsApp messages which come. I can see that you are running around. You are having a skater in the hand leg.
ஆமா சார். எலெக்ஷன் டிஸ்பியூட் இருக்கு, நிறைய வந்துட்டே இருக்கு.
அதான் சொல்றேன்.
Good afternoon.
Hi, good afternoon. Why is President Saab? Good afternoon.
Good afternoon, sir. Good afternoon.
Ma'am, Vidya ma'am.
Vidya?
Ma'am, can you try sharing your PowerPoint, ma'am? அது வரதான்னு மட்டும் பாருங்க.
Vidya?
இருக்காங்கன்னு நினைக்கிறேன்.
ஹலோ
வித்யா உங்களோட PowerPoint கொஞ்சம் ஷேர் பண்ணுமா?
ஓகே.
Hi Kanaka, good evening. Good afternoon.
Good afternoon, sir.
நீங்க உங்களோட ரெஸ்யூமே அனுப்பவே இல்லை எனக்கு நீங்க.
எனக்கா? ஐயோ சாரி.
Yes, madam.
Pillar of Ima Chennai South present பண்ணிடலாமா?
Madam.
Madam, you are good to go, ma'am. இப்போ unshare பண்ணிக்கோங்க, ma'am.
Okay.
Thank you very much.
Okay, sir. Okay.
Thank you.
Shall we start the meeting?
Okay, madam.
Yes. Good afternoon, everyone. Adopting the medal by President and meeting call to order.
சரி.
President, sir. TVN, sir.
வதரே லைன்ல.
TVN, sir.
Dr. C. Aunter.
President, sir.
மீட் பண்ணல மேடம் அவர் அன்மியூட் பண்ணல.
Yeah.
Sir. Okay, thank you. Meeting call to order, please. Meeting call to order.
Meeting call to order.
Thank you. Physician's prayer. மருத்துவரின் பிரார்த்தனை. எல்லாம் வல்ல இறைவா, உலகின் சிறந்த மருத்துவன் நீயே. உன்னை மண்டியிட்டு வணங்குகின்றேன். உன்னிடமிருந்து நல்லதும் சிறந்ததும் என்னை அடைய பிரார்த்திக்கின்றேன். எனது கரங்களுக்கு திறமையை தாரும், எனது மனதிற்கு தெளிவான பார்வையை தாரும், இருதயத்துக்கு இரக்கத்தையும் கனிவையும் தாரும். எனக்கு அளிக்கப்பட்ட சிறப்பு தகுதியை தக்க வைக்கும் எண்ணம் வாடும் மக்கள் படும் பாட்டினை சிறிதளவாவது போக்கிட ஒன்றுபட்ட எண்ணத்தையும் வலிமையும் தாரும். என் மனதிலிருந்து தகாத எண்ணங்களையும் உலகளவு ஆசையும் அறவே ஒதுக்கி பணி செய்திட அருளுமாறு குழந்தை போன்று உன்னை சார்ந்து வேண்டுகிறேன். இந்திய மருத்துவர் சங்கம் வேண்டுதல். எல்லோரும் மகிழ்வுடன் வாழ, எல்லோரும் நலமுடன் வாழ, வலி என்னும் தொல்லை நீங்கி அல்லல் செய்யும் இன்னல் நீங்க, பேராசை பிரதிபயன் அகற்றி பிணிபோக்கும் பெரும்பணி ஆற்றுவோம். We have one obituary. One of our members, Dr. Chitra, passed away last week. So those who know about her can say a few words about her. She lost her husband, who is also our member, Dr. Shanmugam. He passed away in the month of May, but we came to know only last week.
I know her. I used to see her in Dr. Chitra. I used to meet her in Dr. Malliga Sri Nursing Home at Saida Pet. She used to be very calm and quiet, polite lady. And she's very, a pious lady also. So I operated on her a few cases. We lost her. We'll pray for her soul rest in peace.
Yes. Anybody else? Anybody else who know her? We'll have a 1 minute silence, please.
Yeah.
Yes. Proceed with the program. We request our welcome address by our president, Dr. C.V. Natarajan.
Good afternoon, everyone. Good afternoon, Ramakrishnan sir. Again, we are meeting for the CME this month amidst COVID virtual meeting. Hopefully, we'll have a physical meet sometime soon, provided the situation improves. I'm sure we'll have a nice time in the afternoon today with a lot of scientific information. Thank you very much. I welcome the speaker also. All the best for everyone. Let us get on to the meeting. Thank you.
The secretary's report. This is a report from the month of October 2021. We had only 2 CMEs this month. World Mental Health Day was observed. On the 9th of October, it was a virtual program. The topic was suicide. Dr. Maragadamani was the chief guest. The speakers were Dr. Vasant and Dr. Janani Bragadish, both from our branch. Dr. Vasant spoke on epidemiology, stats, and etiology, and Janani spoke on management and current legal scenarios. On the 10th of October, Dr. Maragadamani, Dr. Saravanan, Dr. Shankari, and myself attended the 310th State Council meet. Dr. Saravanan was inducted as the North Zone Vice President, and myself inducted as the Women Doctors Wing Chairman. On the 15th for the year 2022. On the 15th of October, we had the 8th episode of Papyrus to Pump, History of Medicine, Biography of Diabetes. The topic was Diabetic Resurrections. The speaker was Dr. Nallapellumal, our member and diabetologist. Our state president, Dr. Ramakrishnan, was the chief guest. Dr. Palanisamy, president-elect 2022. Now he is the president. And Dr. Maragadamani, our North Zone vice president, were the guests of honor. Dr. B. Mohan of Mohan's Diabetic Specialty Center was the special invitee. Our diabetics CME was also live streamed in YouTube. The 24th of October, our branch members won finals in solo singing and Rangoli. Dr. Janani won the first prize in singing, and Dr. Vishwapriya from Ranga Nursing Home secured 3rd place in Rangoli. Our congratulations to them. Dr. Janani has been selected for the nationals also. We also we lost one more person due to COVID complication. Dr. Chitra died of cardiac arrest on the 30th of October. May her soul rest in peace. Her husband, who was also a member, died of COVID-19 in May 2021, and we came to know only about it on the 9th of October. Condolences were passed on to their daughter. Dr. Ravindran, our ex-president, conducted eye camps, total camps 4, number of OP patients 417, total number of IP surgeries done 23. We have only 17 days left to avail the benefits in membership fee reduction by the state office. Kindly enroll more members who will be of benefit to our branch. Our membership fee for single is 14,000 and for couple is 19,500. 4 more members are inducted into our branch. 3 of them were proposed by Dr. Saravanan. They are Dr. Vijay Kumar, Dr. Nagamani, and Dr. Murugesan Nagamani, both father and son joining together. And Dr. Sampath Kumari's son-in-law, Dr. Arun, is also joining us. Thank you for Next month, we will be announcing the date for election to various posts in our branch. Request young, energetic members to take up the posts and to bring glory to Ima Chennai South. The various posts are Vice President, Honorary Secretary, Joint Secretary, Assistant Director Studies, Assistant Secretary Studies, Women and Doctor Wing Chairperson, Secretary WDW, Assistant Secretary Membership and Culture, Private Hospitals and Nursing Home, Factory Eradication, Research Wing, EB members. Those who are in some posts, if you want to continue in the same post, then also you have to apply. We will be sending the forms in the first week of December. Our final CME is on the 19th of December, along with AGM. Because on the second Saturday, we will be, on the 11th of December, we are attending the state conference at Coimbatore. So it will not be possible to have it on the second Saturday. So we will have it on the third Saturday, that is on the 19th. On the 14th, we have our EC meeting. Thanks for your patient listening. Thank you. Ramakrishnan sir, your address, please. Chief
Hey, very good afternoon to everybody. And Dr. C.V. Narajan, President, Dr. Santhanarayanan, Secretary, and Dr. Mangaisa, Treasurer, and two eminent speakers, Dr. Vidya Narasimhan and Dr. Saravanan of Chennai, and other participants, Dr. Kanagavel, Dr. Mari, Dr. Rukmani, Dr. Chandrasekhar Rao, Dr. Sita Lakshmi, Dr. Yasoda, and Dr. Raman. It's my pleasure to be here with you for every CME program, and we don't miss you also whenever you invite us, and we are regular and you are also regular. And I think during our award ceremony, I hope Chennai South will get an award for the CME regularly conducted during this year. I hope you will get the award. And today's speaker, Dr. Vidya Narasimhan and Dr. Saravanan, they are going to give us good details about laparoscopic surgery and also brain tumor common symptoms. And once again, I thank you for inviting me. I wish the CME all the best. Thank you.
Thank you very much, sir. Thank you. Next, Dr. Maragathamani, madam.
Good afternoon to all. I welcome you for this CME. And this morning we had a very interesting session for the school children regarding the mental health issues faced during this pandemic period by our member, Dr. Janani Bragadish. It was a very useful one, not only for the children, but also for adults. And all the children and the teachers of the MCTM school, they really appreciated the talk, and thanks to Dr. Shanta for organizing to celebrate the mental health day. And this month CME, we are going to have two speakers. One is Dr. Vidya Narasimhan, and she's going to talk about complications of brain tumor, and our own member and future North Zone Vice President, Dr. Saravanan, is going to talk about the laparoscopy. So I am very eagerly waiting to listen to the topics. So let us go into the CME. Thank you.
Thank you very much, madam. Now the introduction of the speaker by Dr. Yasoda.
Good afternoon to everyone. Today's we have two topics. The first topic is on common neurological symptoms of uncommon diseases, namely the brain tumors, by Dr. Vidya Narasimhan, an MCH, an Associate Professor of Neurosurgery from Madras Medical College. She is a graduate of Coimbatore Medical College. She has done her MCH Neurosurgery from Madras Medical College. She has served in various government medical colleges from 2001. Currently, she is the Associate Professor of Neurosurgery in Madras Medical College. She is a visiting consultant neurosurgeon in various hospitals of Chennai. Her special interests are neurotrauma and neuro-oncology. She has presented several papers on brain and spine. She has presented at national level, and she has chaired several conferences too. Today's topic, brain tumor, is the one of interest for Dr. Vidya. Brain tumor, as you know, all of you know, depending on the site of occurrence, size, and spread, can present as with many symptoms, particularly headache, acute or persistent, visual disorders like strabismus, nystagmus, loss of vision, and total loss, hemianopia or total loss of vision. Hearing loss also can occur. Nausea and vomiting, dizziness, vertigo are quite common symptoms. Sensory loss or paresthesia, motor problems like difficulty in walking, facial weakness, muscle weakness, coordination difficulties, paresis in the form of monoplegia, hemiplegia, or quadriplegia. It can also present as mental confusion, speech disorders, and language problem, personality changes, sleepiness, and seizures. So you name it, everything is possible with brain tumors. Hence, we need clarification regarding the presentation of brain tumors. And over to you, Dr. Vidya Narasimhan, to delineate these problems to us.
Thank you, Dr. Yashoda Madam, for that nice introduction. And you almost narrated all the symptoms and made my job very easy. So we will good afternoon to all senior members and friends. I am Dr. Vidya Narasimhan. I'm working as Associate Professor of Neurosurgery at Madras Medical College. I'm also a freelancing consultant neurosurgeon at various hospitals in Chennai, including Kaveri Hospital at Mainapur. So today we will see about the common neurological symptoms that one comes across in their daily practice and how they are related to uncommon diseases of brain like brain tumors. Headache is one symptom that every one of us would have experienced ourselves and would see commonly in our daily practice. So a headache patient could be due to a migraine or a tension headache or sinusitis. But certain symptoms, if they are added to headache, it makes it pathological. If the patient has a bifrontal region headache associated with vomiting and the headache happens early in the morning, and if vomiting relieves the headache, all these features are suggestive of intracranial pressure. An ICP headache could be due to a brain tumor, which is there in the and causing edema and mass effect in the brain. Or it could be due to a posterior fossa tumor with associated hydrocephalus, which is causing the pressure. Or it could be due to idiopathic intracranial hypertension, where there is no tumor, but the CSF is under pressure. The second type of headache could be a focal headache in some part of the head, which is due to dural stretch headache, which occurs in the tumors called as meningioma. This meningioma being attached to the meninges causes the stretching of the meninges and causes some vague headache. These are very benign tumors. They grow very slowly, but if it is identified early in the smaller size of the lesion, we get a better prognosis. A patient may come to us with a thunderclap headache, which is a sudden severe headache, and patient says that this is never in my life headache. First time I am experiencing this kind of headache. So it could be due to a subarachnoid hemorrhage, which is due to a ruptured aneurysm. A patient after delivery may come up with vague headache, which could be due to cortical venous thrombosis. Cortical venous thrombosis also occurs after dehydration and some coagulation disorders. A typical cough headache occurs in classical Chiari malformation, wherein the cerebellar tonsils lie little below the foramen magnum, entering at the level of the C1 spine. It could be associated with syringomyelia. A facial pain, which is lancinating and occurs on and off, which is called as a trigeminal neuralgia, could be due to a vascular conflict due at the root entry zone of the trigeminal nerve, or it could be sometimes due to a tumor in the CP angle. The second common symptom that everyone comes across is seizures. When a seizure is late in onset in adulthood, if it is focal in origin, and if it is associated with a post-ictal hemiplegia, then it is highly suspicious of tumors of the brain, especially of the frontal lobe or the temporal lobe. Some patients with seizures over a long time in the form of an epilepsy could also be due to some tumors like vascular malformations, cavernoma, which presents only as seizures over a period of years, or it could be due to a DNET, a tumor of embryonal origin, which manifests only as seizures, or it could be due to a medial temporal sclerosis, that is scarring of the hippocampal region of the brain. So next symptom is a weakness of limbs. The conventional stroke is usually acute in presentation. When somebody has hemiparesis of insidious onset and gradually progressive, it could be due to a tumor of the brain, either involving the motor cortex or in the capsular region, internal capsular region. So we have this image shows that there is a tumor involving the internal capsule. If a patient presents with other cerebellar symptoms and signs like ataxia and incoordination, it could be due to a cerebellar tumor, as we see in this image. A patient might also have multiple visual symptoms, starting from visual obscuration, which is the dimness of vision at the peak of headache. And on examination of the fundus, the patient might have papilledema, as seen in this image, which is an indication for raised intracranial pressure, which could be due to any of the above said tumors. Regarding the field defects, if a patient's fields are showing bitemporal hemianopias, or if the patient gives history of not able to view objects to one side of his field, that could be due to tumors of the stellar and suprasellar region, namely a pituitary tumor or a tumor which is a meningioma, which is in the parasellar region. Unilateral visual loss along with proptosis can occur in orbital tumors. If there is a bilateral vision loss, it could be even due to a late stage of papilledema, wherein the nerves go for optic atrophy. In the examination of retina, if the patient has a retinal angioma, it could be an indication for a hemangioblastoma of the brain. Together, the syndrome is called as von Hippel-Lindau syndrome. About the other cranial nerve dysfunction, anosmia has been very common after the COVID, but if there is a persistent anosmia in a non-COVID patient, it could be indicative of a tumor involving the olfactory region, like astheneoblastoma or olfactory groove meningioma. This picture shows the olfactory groove meningioma, which occurs in the anterior skull base and contains very huge size before presentation because the patient has only smell loss, which is often ignored. The patient might also have involvement of 3-4-6 cranial nerves in the form of ocular palsy, or it can have diplopia. So this is due to some tumors which involve the cavernous sinus region. There is a classical symptom of upgaze palsy with convergence retraction nystagmus, which is called as Perinaut syndrome, which occurs in pineal tumors. Pineal region is the central region of the brain, and it hosts many number of tumors in that region. A patient might also present to us with unilateral hearing loss. Though hearing loss could be due to many reasons of the ear, a sensorineural hearing loss of unilateral origin should be a point of concern. If it is associated with some facial numbness, which usually occurs late, or with cerebellar symptoms, it gives us a diagnosis of a CP angli tumor, cerebellopontine angli tumor. A patient with tumors of the jugular foramen may present to us with swallowing difficulty. Higher function disturbances in the form of speech disturbances and memory disturbances could indicate a tumor of the temporal lobe. There are patients who have small memory disturbances lasting for 10 years or so, quite ignored or assumed as a normal variation, and found to have very huge tumors of the skull base, of the medial skull base, which are benign meningiomas, but they grow to such extent that it becomes sometimes inoperable. A subtle behavioral change or a bladder incontinence could be a sign of a frontal tumor. A patient who is presenting with a secondary amenorrhea along with galacturia might be lodging a pituitary tumor, which is called as a prolactinoma. In an adolescent child, if there is absent secondary sexual characters along with short stature, the faces of a craniopharyngioma child will be actually very classical to recognize just by seeing the child that this child might have a craniopharyngioma. The other hormonal symptoms are Cushing syndrome and acromegaly, which could be due to secretory pituitary tumors. In the emergency room, a patient might present with status epilepticus or unconsciousness. This could be due to a tumor which causes severe edema and midline shift, and it could also be due to acute hydrocephalus, which is a result of a tumor causing ventricular compression and increase in size of ventricles, or a cystic lesion like a colloid cyst, which is notorious for producing sudden acute hydrocephalus. It could also be due to a tumor which is there for quite some time, and there is a tumor bleeding which causes sudden increase in intracranial pressure. Pituitary tumors can also present in an acute scenario where the pituitary tumor bleeds and causes sudden apoplexy and shutdown of all the hormonal axis, and the patient becomes unconscious. In pediatrics, in the infants, a large head is pathological. It could be due to just excess CSF in the form of hydrocephalus, or it could be due to brain tumors. If there is a brain tumor, in addition, the child would have refusal to feed, incessant cry, and vomiting. If the child has a swelling in the low back at birth, it could be due to myelomeniingocele or a lipomeniingocele. If there is a tuft of hair in the low back, it indicates an occult malformation like a split cord malformation. In older children, if children present with headache, vomiting, and ataxia, it could be due to posterior fossa tumors, which is the commonest site of tumors in children, or it could be due to brainstem tumors. Here again, this image is an image of posterior fossa tumor, and this is a craniopharyngioma, a child with absent secondary sexual characters and a short stature. Even dermatologists will cross patients for large the case of capillary spots and cutaneous neurofibromas. These patients might lodge a variety of tumors, one of which is optic glioma. The second image shows a tuberous sclerosis patient with adenoma sebaceum. They may also have other things like shagreen patches, which are indicative of tuberous sclerosis. Intracranially, these patients have a peculiar type of lesion which is unique for tuberous sclerosis, which is called a subepidermal giant cell astrocytoma, which is there in the ventricle. This is very unique only for tuberous sclerosis. So what happens inside the brain when there is a tumor? Tumors of the brain can be broadly classified as extraaxial and intraaxial. Extraaxial means it is outside the brain parenchyma and compresses the brain, as like the meningiomas. Intraaxial are the tumors which are within the parenchyma, and they cause destruction of the normal neural nerves rather than compression. In addition to this, there is destruction or involvement of the neurons. Many tumors produce a lot of edema around them, which causes cerebral irritation, thus causing seizures, or it causes mass effect, midline shift, and makes the patient unconscious. Some tumors like meningioma, whether they have edema or not, they grow slowly and to a giant extent over a period of years and causes severe intracranial hypertension. Now let us see about these tumors. So far we looked from the perspective of symptomatology. Now let us look at from the perspective of tumors brain and their symptoms and management. The spectrum starts from tumors like gliomas, meningiomas, schwannomas, ependymomas, vascular malformation also is considered space occupying lesions, pituitary adenomas, cystic lesions of brain, and post-infectious tumors of brain. Meningiomas are relatively benign tumors. They are extraaxial, that is, they arise outside the brain parenchyma. They are highly vascular, they are slow growing, and generally they present late to the clinician because they produce only mild headache, which is quite ignored. And craniotomy and complete excision is the treatment of choice. If diagnosed early, they have very good prognosis. They can arise from any part of the dura, wherever the dura is reflected over the surface of the brain and also in the base of the skull. So they can arise from anywhere like the surface dura, like convexity meningioma. They can get attached to the falx. They can get attached to the superior sagittal sinus. They can have extensive edema and cause mass effect and midline shift. They can arise from the middle skull base or any skull base region. The second tumor is a glioma, which in turn has a spectrum of grade 1 to grade 4. It occurs from pediatric to geriatric group and it arises from the supporting glial cell. The first image shows a cerebellar pilocytic astrocytoma, usually occurs in children. It is grade 1 and it is amenable to complete excision. If excised completely, it has very good prognosis. The second image shows a diffuse astrocytoma, which is grade 2, which usually occurs in the middle age group and has a relatively good prognosis of more than 10 years survival. This image is grade 3 astrocytoma, otherwise called as anaplastic astrocytoma, which has severe edema, mass effect, and this is grade 4 glioblastoma, which spreads faster than grade 3. Both are treated by surgery followed by radiochemotherapy and have a prognosis, say 5 years for grade 3 and 2 years for grade 4 in spite of all our treatment. Brain is also a favorable spot for deposits of secondaries from areas like lung, breast, and prostate. Usually, secondaries in the brain are multiple. Sometimes it could be single secondary, and it is associated with disproportionate edema in the brain. So, whenever we come across a patient who gives us a history of these breast tumors, are notorious for having delayed secondaries in the brain. The patient will be looking like as if they are completely out of the disease, and they will present with the secondaries in the brain in a later stage. So anybody who gives a history of past history of treatment, surgical treatment for a tumor elsewhere, and some history of headache or seizures, we are supposed to evaluate them for metastasis brain. If the primary disease is completely controlled and the brain has a single metastasis, it can be operated with complete cure. Otherwise, if there is edema and mass effect, palliative surgery can be done for the temporary relief, followed by radiochemotherapy. Pituitary gland, which is the master gland of all the endocrine system, is notorious to have tumors in the form of pituitary adenomas. It could be secretory or non-secretory. If it is secretory, it produces high hormones like prolactinoma. It can even produce Cushing's disease or acromegaly, depending on the hormone which is produced with the tumor. Non-secretory pituitary tumors cause compression of the normal pituitary and produce hyposecretion. So, in addition to having hormonal disturbances, pituitary tumor patients, once it increases in size, these pituitary tumors go and compress the optic chiasm, which is lying just above the pituitary, and hence it causes bitemporal field defects in the visual field. The tumor of the pituitary is these days managed by endoscopic excision of the tumor, as shown in this image. Ventricles also lodge different kinds of tumors, which starts from a cystic lesion commonly called as colloid cyst, and this which is shown in this image. And this is the endoscopic view of the colloid cyst, which if it is small can be excised endoscopically. And other tumors of the ventricle are ependymoma, which arises in the layer of the ventricle, or choroid plexus tumor, which can be benign or malignant, which arises from the choroid plexus. These ventricular tumors usually present with hydrocephalus, ICP, and headache alone. They don't have any focal signs. Like if a frontal tumor or temporal tumor is there, there will be some focal signs. These patients will present only with headache and ICP. It can be managed either open or endoscopically. The cerebellopontine angle is a unique location between the cerebellum and the pons, where the 7th and 8th nerve complex leaves the brain and goes to the ear. This is notorious for having a common tumor called as vestibular schwannoma, which arises in the Schwann cells of the 8th nerve. Along with causing hearing loss, it also compresses the 5th nerve and 8th nerve, which are adjacent in that area, and also when it grows further, causes distortion of the brainstem. and even causes brainstem signs. It also compresses the cerebellum and causes cerebellar signs. The mainstay of treatment for this is total excision. Brainstem per se can have lesions which can be a simple cavernoma, tuberculoma, or tumors like gliomas. Brainstem lesions, some patients with brainstem tumors can be operated and some go for direct radiotherapy. The commonest malignant pediatric tumor is medulloblastoma, which arises from the roof of the fourth ventricle in the posterior fossa. It presents in the young age with refusal of fluids, vomiting in older children in the form of ataxia and headache. It is one of the most malignant tumors of pediatrics. The treatment, mainstay treatment is surgery followed by radiochemotherapy. Pineal region of the brain is one location which is the center of the brain, which is lodging quite different types of tumors like tectal gliomas, spinellomas, spinoblastomas, germinomas, meningiomas, and even epidermoid cyst. The surgery for pineal tumors are quite different, and the patient is made to placed in a sitting posture and operated on, because the trajectory to the tumor is far away from every surface of the brain. So a trajectory between the cerebellum and the occipital cortex just below the tentorium is chosen, which does not have any vital structure, for which the patient is operated in a sitting posture. Brain also lodges few cystic lesions like arachnoid cyst and epidermoid cyst. This image shows an epidermoid cyst of the posterior fossa, which is just like our dermoid or sebaceous cyst, has pulpaceous material. Though the tumor is benign and innocuous, it can cause compression, and this epidermoid cyst is renowned for growing in between the cranial nerves, and it is compressing all the cranial nerves and involving extending, it creeps between the nerves and keeps on extending over a period of years. The treatment for this is excision. This image shows a surgical image of epidermoid cyst of the posterior fossa. There are certain vascular malformations of the brain which present like tumors. The first one is a cavernoma, which is a venous malformation. It presents with seizures over years, and it has a hemosideral ring deposit. And this is the scan image and the intraoperative image of a cavernoma. Excision is the treatment. As we saw previously, a patient might present with sudden severe headache, which could be due to subarachnoid hemorrhage, which is in turn due to aneurysm of the vessels, which is picked up by this DSA. And these patients, this is an intraoperative image of a middle cerebral artery aneurysm, which is being clipped. And the other modality of treatment for this is endovascular coiling. Infections can present like tumors in the brain. The neurocysticercosis, which is caused by tinea infestation, can present with multiple cystic lesions in the brain. It causes seizures and headache. It can be managed medically. Tuberculoma presents in the brain as ring lesions with severe edema. Here also it can be managed medically unless it is of very big size. Pyogenic abscess in the brain can occur from the ear, that is otogenic, or through the blood. So these abscess brain are managed by either tapping and removing the pus, and if it does not come out fully, then excision by surgical. So what happens in the OR? How these patients are operated? Let us peep into the OR for a moment and see what happens there. This is a MR image of a meningioma called as a convexity meningioma, quite big in size. The neurosurgical procedures are done using this operative microscope, which increases our view to 10x. This is the intraoperative view of the tumor, where the tumor is seen here. It's an extraaxial tumor. It can be easily separated from the brain. This is how it is being dissected from the surrounding brain, and the complete excision is achieved. This is another meningioma immediately after reflecting the dura and exposing the tumor, and after the excision. The third case is a case of gliosarcoma, which is in between glioma and meningioma. This is the intraoperative image. Unlike the meningioma, it is just like the brain, except that it is little hyperemic. Except that there is no difference between brain and this. This is after the complete excision of the tumor, and the patient recovered with no neurological deficit. So early identification of the tumor by picking up these symptoms early helps us prevent such enormous growth of some tumors which are growing for years together, going unnoticed, and then presenting in an inoperable stage, engulfing almost all the vessels of the brain. Thank you for your patient listening.
May I ask a question?
Yes, thank you.
Yes, please, sir. Yes, sir.
Thank you for covering all aspects of brain neoplasm.
Yes, sir.
I have a question.
Yes, sir.
Symptomatically, the patient gets up from the bed during sleep.
Yes,
Is
sir.
it significant of malignancy of the brain?
You mean to say sleepwalking, sir? Or
No. Patient gets out of sleep from the bed during sleep due to headache. Gets
yes,
up
sir.
from the bed, awakens.
Yes, sir. Headache,
Nocturnal headache. Nocturnal headache, solraru.
If the early morning headache or waking up due to headache is highly suggestive of intracranial pressure, sir, we have to rule out a lesion.
Very good. Then how common is the recurrence in meningioma?
Meningiomas, when detected early and excised completely, they don't recur, sir. Some meningiomas are invasive of the superior sagittal sinus, wherein for the purpose of maintaining the life of patient, we would intentionally leave a small bit of tumor inside the superior sagittal sinus, or a small bit of tumor which is engulfing a carotid artery. So those small tumors may grow over a period of time, like say years, 5 years, 10 years down the line. So if it is detected early and excised completely, they don't recur.
Thank you.
Madam, Dr. Vidya, Madam, Dr. Sudhirmurthy here, pulmonologist.
Yes, sir. Yes, sir.
I am a student of Dr. T.S. Kanaka.
Great, sir. Great, sir.
We have done a lot of work on tuberculoma brain.
Okay, sir.
How common nowadays tuberculoma brain?
It has come down drastically, sir. In my PG period, we used to see so many of them. Right now, I have one patient in my ward who's having all the spectrum of TB, starting from meningitis, post-meningitis, sequelae, tuberculoma, everything is having. But it is not as common as...
Is it immunocompromised patient?
No, sir. He is not immunocompromised. But surprisingly, this patient had a shunt dysfunction. So for which we did a revision of shunt. And the shunt tube had black color material, which we sent to microbiology, turned out to be aspergillus.
Oh, God.
So we still don't know whether the primary tumor also was fungal. And we sent for the primary tumor was biopsied elsewhere. We sent that biopsy again to our department, reported as tuberculoma. So we are treating him for both antifungal and ATP.
Thank you, madam. Thank you.
But the incidence has gone down.
Yeah,
really.
definitely. I agree with you. Agree.
Yes, sir.
Tuberculoma and neurocystic psychosis are usually the differential diagnosis.
Yes, sir. Yes, sir. Very true, sir. But both we don't see much these days, sir. Even brain abscess has come down drastically. Before 10 years, we used to see at least one abscess per week or even more than that. Now we don't see, because all ear infections are treated better and they don't get complicated and spread to the brain.
How long this ATT therapy should be given for tuberculoma patients, generally?
Sir, any neural tuberculosis at least for 1 year, sir. 1 year,
okay. So unfortunately,
it is extended short course therapy, extended short course. So at least for a year.
Yes, sir.
Okay. At least in your surgeries, the clearances will be very microscopical, unlike other cancer surgeries. So recurrence rate is little more in neurosurgery.
Yes, sir. We have to juggle between preserving nerves and be very aggressive on tumors. In gliomas, it is not possible to delineate where the tumor ends and where the normal brain starts. So we have to err little bit, leaving the tumor, which can be taken care by the radiochemotherapy, rather than removing some part of brain and giving a deficit.
Thank you.
Unmute yourself. Unmute. Yashoda, unmute yourself.
Yes, ma'am, in pediatric age group, we specifically get midline tumors. Why should there be such a predilection?
Midline tumors, there is only one central neurocytoma, medulloblastoma. Medulloblastoma is not considered as a midline tumor, ma'am. It is like, it is all because of the embryology. All the nerve cells originate from the ventricular wall and migrate upward in embryology. That's why all those embryonal tumors are towards midline or towards the ventricles.
And the second question is, what is the optimal therapy for neurocysticercosis, ma'am?
It is only 6 to 8 weeks of helminths. That's all. Nothing. I only specific point is, madam, before starting on anti-helminths, we have to give steroids, because if the anti-helminths are going to kill this neurocysticercus tumor, the organism, if it is live, will cause some reaction. So at least 24 to 48 hours of steroid before starting anti-helminths. That's all.
Yeah. Okay. Thank you, ma'am. Thank you.
Any more questions? Thank you, Dr. Vidya.
Thank you, madam. Thank you for giving the opportunity.
Shall we go to the
we are the
second,
beneficiaries.
Shall we go to the second topic?
Yes.
Madam, take over.
Second topic today is by Dr. Saravanan, laparoscopic limitation for hernia repair. Dr. Saravanan is an MS general surgeon with a specializing in laparoscopic surgery. He is the chairman and MD of Girishwari Hospital. He is the pillar of strength to Ima Chennai South. He wantonly refused to give his resume, but we all know him too well. So there is no need for further introduction to Dr. Saravanan, who had been spearheading all our activities, either clinical or academic or otherwise. So over to you, Dr. Saravanan.
Thank you, madam. Thank you for your kind words. Respected State President, Dr. Ramakrishnan sir, our North Zone Vice President, Dr. Maragdamani, our own beloved President, Dr. CVN, and our Secretary, Dr. Shanta madam, and Dr. Mangai, our Financial Secretary, and friends. Good afternoon to everybody. I chose this topic because I'm very kind of well-versed with hernia surgeries. Also in now recent days, laparoscopic hernia repair is commonly what we do. Especially I chose because I come across so many problems and complications, so that when we have to limit our extent to the laparoscopic repair of hernias. So that's why I chose this topic especially. It's generally for surgeons, and of course the common general practitioners also should know, other department people also should know. That is the aim of this topic. So can I share my screen?
You'll be able to do it. Anaka, I'll give you the 1 second.
Kanaka?
Kanaka?
Kanakavel, Dr. Kanakavel?
He's got a meeting there and he's in Bombay. Yeah.
So actually this is taken of all these videos and pictures and all taken from my own collections. So before that, I want to give an overview of what is hernia. Hernia is a protrusion of an organ through a normal or abnormal opening, which is lined by a sac. If it's not lined by a sac, it's called procedentia. And most of the hernias we come across are abdominal hernias, among which the inguinal hernia is the commonest hernia we come across. Next one. So the abdomen itself is a Pandora box. No, when you go inside, you have lot of organs, lot of muscular layers, and everything is different, and the combination is so good. And some of the places where the muscular strength is very less, the peritoneum try to push and come out of the abdominal wall. And especially it's in the inguinal region, umbilical region, para-umbilical region, and spigelian area. This is all the commonest place we come across hernial projections. Generally, it's all depends on the Pascal's law. When the pressure is given to one point, the pressure inside the abdomen is exerted all around the abdomen or the cavity equally. So wherever the resistance is less, the hernia will appear in that area. So these are all the common, and it can be typed as congenital, and due to aging, because the collagen content of the tissues is less, the muscular strength is also going down. Aging also weakens the abdominal wall muscles, which causes hernia, especially where the least resistance is there. And damage from an injury or surgery, we come across a lot of incisional hernias. Previously, it was associated with the midline or paramedian incision. Now, most of the, because of the advantage of suture materials, as well as the techniques, what we learn over the years, which reduces the incisional hernia nowadays. And of course, the strenuous exercise or weightlifting, people who lifts heavy weights, not only sports, other means also, they have developed a lot of inguinal, mainly inguinal hernias. The chronic coughing or chronic obstructive pulmonary disorders, COPDs and COPDs, they have, they develop hernias. And of course, pregnancy, especially having multiple pregnancies, and they develop divarication of recti as well as hernias, very common, especially umbilical and para-umbilical hernias. And of course, chronic constipation, when sit on the commode and strain yourself, and intra-abdominal pressure goes up, and the least resistant portion comes out as hernias. And of course, overweight, and you know the fat is the main driver of hernia. The peritoneum, the extraperitoneal fat drives the sac through the least resistant area, so they develop hernias. Next, the management of hernia, mainly it is surgical because it is only a mechanical defect. We can't heal it by medicine or any other method. And previously we were doing open repair. They are again divided into herniaplasty and hernia raphe. And nowadays, mainly laparoscopic repair, IPOM, that is intraperitoneal onlay meshes. That also a lot of varieties are there, and tap a transabdominal preperitoneal placing of the mesh, and totally extraperitoneal placement of the mesh. This we call as IPOM and tap and tap. What are the complications we come across by repairing the? If you don't repair, if you don't repair and don't care about the hernias? So it may go in for irreducibility, where the contents will come out and get stuck, where you cannot reduce it. So, and the content can go in for incarceration and obstruction. Suppose if it's a bowel, small bowel or large bowel, it get obstructed. Again, it will go on for gangrenous change also. Sometime we may end up in having resection and anastomosis, doing resection and anastomosis of the small intestine or large intestine, whatever getting strangulated, and rupture of the sac. The sac, if it would rupture because of the tension, that also can develop into fistula formation if the hernial content is a bowel. So, next slide. These are all the methods we do. This is the hernia through, if it is a bowel, we have to reduce the content of the bowel. Onlay, this one is by only open methods. onlay meshes, the mesh is a blue line, which is kept onto the rectus sheath after approximating the peritoneum and muscle structure, if anything. And sublay mesh is, we have to keep the mesh just below the rectus sheath. And again, if peritoneum is, peritoneum should be closed before that, and keep the mesh and fix it on either extent, that is on the linea sublinaris, then approximate the recti muscles. And then the underlay mesh, which we don't commonly do it open repair, except we have a specially designed mesh where you can just push in the mesh and hang it by blind methods only. It's a little dangerous. And inlay meshes, just keep the mesh on the hernial orifice and stitch it, fix it. This is for open method. And then the laparoscopic hernia repair, intraperitoneal onlay meshes. Most of the time we follow this for incisional hernias, umbilical hernias, paraumbilical hernias, and all that. And this is the way we keep, because we are going intraperitoneally, and reduce whatever the content here. And it's very simple, for understanding. So just we have to use dual meshes for this repair, because dual mesh is coated on either side of the mesh. One side is smooth. So smooth side should be kept on the bowel side, and the rough side will be on the abdominal wall side. Because suppose if you keep a regular proline mesh in these areas, the intestine is tend to adhere to the mesh, which we just did one case yesterday. I'll show you the video later. So to avoid these adhesions, later on adhesion colic and intestinal obstruction, we have to use dual meshes to fix these hernias. And then next one is TAP, that is transabdominal periperitoneal mesh repair, where, reduce this. Yeah. So the green color here is the mesh. You go intra-abdominally, dissect the peritoneum and lift a flap along the peritoneal surface, extraperitoneal surface, create a space and keep a mesh over here, and then put back the peritoneum, tack it. If you want, you can tack this mesh also. Predominantly, we use to repair this inguinal hernias in this way. Also, we can use what is called TEP, that is totally extraperitoneal placement of the mesh. This is, we are dissecting extraperitoneal. We are not going into the abdominal cavity. We are just dissecting onto the extraperitoneal space, go all the way to this umbilical area where we can find the extraperitoneal space easily, and dissect along the peritoneal space and put a mesh over there. This is inguinal pubis and the other structures. We can keep a mesh. The green line is the mesh. So this is TEP method. So why we prefer laparoscopy? This is for laparoscopic hernia repair. Of course, the laparoscopic, whatever the advantage we have for laparoscopic procedures, the same advantages, also some added advantages also there. So the safety is increased. These days, the learning curve is better, so that even young surgeons are doing the procedure so well, and the recovery is very fast. In fact, on the same day or the next day, patient can be discharged, and they can be started on oral feeds on the same day itself, and less injury to the tissues. As of course, blood loss is less and scarring is less. Patients who wants small cosmetic scars, we can prefer laparoscopic surgeries, and also the precision in performance. I will discuss this during this yesterday's surgery, what we did. Adhesiolysis, just dissecting the small bowel from the mesh, the vision is very good, and it is enlarged at least by 3 to 5 times than the open surgeries. And of course, the less pain. These are all the reasons we prefer laparoscopic surgery. Nowadays, almost all surgeries are done by laparoscopy, except the cesarean. And the limitations of laparoscopic hernia repair, there are few reasons why we limit laparoscopic repair of hernias. What are they? They are like, one is increased cost because we have to use the dual mesh, which will cost around 25 to 30,000 rupees. Again, we have to tack the meshes. I don't suture. Tackers again will cost another 25,000 rupees. So this is the cost apart from the regular hernia repairs. So that's also one reason. It's a relative indication. And lengthier operation because actually the time is on time what we take is very less than the open surgeries, and steeper learning curve for the beginners. And nowadays the children are very smart and they are born with computer games, so they can operate faster than us, and higher recurrence rate if it's not done properly. Complicates early in surgery experience. Somebody, hello? And next limiting factors is location of the hernia. The hernia at certain location are difficult to reduce laparoscopically. We find very tough to reduce the contents of the hernia, like femoral hernias, operator hernias. Difficult. It can be reduced when anatomy is well understood, because while going inside the peritoneum, so while open surgery is outside in, which what we read in the anatomy books. Here it is, everything is upside down, and from inside out we have to come across structures and layers. And the parastomal hernias, we have a few cases by experience. Parastomal hernia is actually very easy to repair, provided you have to design the mesh according to the size of the hernia, and you should not strangulate the stoma, colostomy. People who don't understand stoma, parastomal hernias. So the size of the stoma should be exactly defined, and the mesh should be designed accordingly. And intermuscular internal hernias, and intermuscular hernias, it's very difficult, tough because of funds. And keeping the mesh and suturing in that layer is also difficult. So we prefer to do open surgery like lumbar hernias, because we don't prefer to do laparoscopic hernia in lumbar hernias. And the internal hernias like small lesser sac hernias, we don't do laparoscopically. And large diaphragmatic hernia is another challenge, because narrowing the diaphragmatic defect will be difficult. And next point is size of the hernia. The large hernias, though is not contraindication, it can be a challenging task to reduce the contents laparoscopically. Patients with such hernias, especially when being operated by an inexperienced surgeon, may be better served by an open approach. Because sometimes, I had a few experiences. Out of 3 large hernias, 1 is recurred. So if 1 hernia recurs, then your life is gone. And the duration of hernia, chronic hernias, the chronic hernias produce a lot of adhesions to the hernial sac, and it is difficult to reduce the content, and of course dissect the dissect space between the content and the hernial sac. But still we can manage. The fact is, the previous abdomen and abdominal or pelvic surgeries, any prior abdominal pelvic surgeries, again, same cost. The more additions, we have to carefully dissect. You have to spend time on dissection only. Keeping a mesh and tacking is not a big issue. You have to spend time to dissect carefully, because one small hole in the small bowel, patient's life is gone, our life is also gone. So patient may develop post-operatively hernia, infection, intracutaneous fistulae, and infection of the mesh. So many complications. No, you cut a sorry figure. If you don't cut it patiently, you cut a sorry figure in front of the patient later on. The previous operations in the peritoneal space, especially in cesareans where the peritoneum is totally tight, sutured by many of the gynecologists, and dissecting onto the space below phalansteal line will be a tough job. So that it's difficult to do a TEP repair in case they develop hernia, inguinal hernias. And of course, prostatectomy, retropubic prostatectomy patients also difficult to do a repair by laparoscopic. Previous low midline incisions can make TEP repair more difficult. And the contents of hernial sac also matters a lot. If an enterocele, that is intestine, especially with adhesions, it is also a risky task to reduce the hernia intraoperatively and laparoscopically. Then we may have to put extra ports to hold the bowel. So instead of 3 ports, we can put 4 or 5 ports for retaining the reduced portion in the abdominal cavity. The bowel perforations are very common and it must be avoided definitely. The sliding hernias such as bladder, sigmoid colon, and other large bowels are difficult at times to maneuver laparoscopically. We may have to put extra port to hold it in place. And of course, obesity, though laparoscopy is the best choice for any abdominal surgeries in obese patients, the repair of hernia is technically challenging than the normal weight patient, though I thought it has advantage over the reduced pain early mobility. The recurrence rate also slightly more than the common normal weight patients. As I told you, fat is the main driver of the hernial sac. The physiological consequences of pneumoperitoneum may be marked in patients with comorbidities. So with the comorbidities, we have to do minimum exercise on repairing the hernias. Anesthetic fitness, of course, the patient must be fit anesthesia-wise, otherwise you can't. Generally, we do it under general anesthesia. So it's better to have all the consent and all the fitness from cardiologist, pulmonologist, and anesthetist preoperatively. The technical issues also matter. Instruments and scope need to be in good condition to aid the surgeon for successful repair. Limited motions, the degrees of freedom of straight laparoscopic instruments, two-dimensional imaging, loss of touch sensation, intensification of physiological tremor, and poor ergonomics for the surgeon are a few limiting factors in laparoscopic surgery. And who's an ideal candidate for laparoscopic hernia repair? If you don't want to limit, these are all the dictums and criteria you have to fulfill. Patients, of course, with bilateral inguinal hernias, because with the 3 port itself, we can do both side repairs. So your cutting extent is reduced. So patients who require multiple laparoscopic interventions to be done simultaneously, like patient with the laparoscopic, gallbladder stone and appendix and all that, we can do it at one shot, do a laparoscopic cholecystectomy, finish that work and come down to inguinal. We have a lot of cases in this topic, like we have done laparoscopic cholecystectomy, laparoscopic appendicectomy, and laparoscopic hernia repair at the same patient, the same situation, where some people may differ doing a laparoscopic appendicectomy at the same sitting because we are opening the bowel. If you open the bowel carefully, the appendix or gallbladder is not infected badly, you can finish it off in one go instead of putting the patient under many hospitalization as well as the anesthesia risks. And the patient must be able to tolerate general anesthesia, as I told you earlier. Older patients who cannot tolerate open surgery, laparoscopic surgery is the best surgery if they are fit anesthesia-wise. And patients who are who need early mobilization and travels, we give them a choice of laparoscopic surgery. Anemia patients, because the blood loss is less, probably we can give them a chance for laparoscopic surgery. And the patient, those who want cosmetically good scars, small scars, we can give them laparoscopic surgery. This is 10 additions. This is a recent case. The previous, this is one portion of the hernia, what we have seen. This patient come from Royapuram all the way. She wanted only laparoscopic hernia repair. She doesn't want to get opened. And of course, her previous surgery of hysterectomy is 40 years old. She was 50 years ago. And C-section, and now she has come with multiple hernias, sieve-like defect all along the midline incision. You can see these are all the pockets of hernia. This is one hernia on all the aspects, no? all sides, the top, and small hernias here, small hernias here. There's one hernia here. So multiple hernias. We had to do it laparoscopically and slow. I have the video, I'll show you. This is how we do. I apply extracorporeal knots to approximate these available strong rectus sheets to approximate the defects. And then I keep a mesh and tack it. So the repair is good. It's standing. So for the moment, we have this one. So this is the same patient. Just carefully see where this lady who had multiple hernias, sieve-like defect, and while cutting it, so slow. This shows the chronicity of the hernia, where the peritoneum and omentum is almost fused together, and we have to cut it so carefully. Just tease the peritoneum away from the content, away from the omentum. So after testing whatever available, you can see it's so well organized. There was a bleeder in this omentum, which is supplying the peritoneum. So unfortunately, I cut the bleeder. It was bleeding. So carefully we have to dissect. We will change energy sources from harmonic to scissors, and sometimes normal small Maryland instruments. So while cutting, we should be very careful. There was an organized blood vessel here, this side. I will show you. So slow. See, when I cut that, there was a bleeder. So this shows the chronicity of the hernia. It is almost organized, and the bleeder is either from the peritoneal surface or from the omentum. So I had to to repair this, almost we took 2 hours to reduce all the contents. We cannot cauterize this bleeders very casually because adjacent may be, this may be the intestine. So you should not pass the cautery to the intestine area. That moment may be good. After 4-5 days, this cauterized intestine may open and start leaking inside the peritoneum. So that will be a bad scene. So we have to be very careful by dissecting. So after dissecting the peritoneum, see the content. It's only the large bowel on this side. I'm pulling out the content of the hernia. Seems to be sigmoid colon. The sigmoid colon is pulled up into the anterior abdominal wall. Some of the momentum is stuck there. We have to carefully pull it out, because if you don't pull that momentum out, the bulge outside the abdomen will stand erect even after repair. The patient will ask you why it's not repaired completely, or is it recurrence? So to avoid all those, carefully reduce all the content of the hernial sac, either by scissors or by just pulling the content if it is coming, or using the harmonic scalpel. While cutting the peritoneum, we should be careful, because peritoneum and the bowel wall looks same. Both are shiny and shiny structures. You should not cut the bowel instead of the peritoneum. So we should be very careful in doing this dissection. That's why I'm telling you this. You have to spend time peacefully and patiently to dissect. The dissection is the only surgery here. Keeping a mesh or narrowing there's another sac which got only momentum as content. You can see the top defects. So again, it is pulled down. So much of hernial cavity. There's another sac down there. I'm pulling out the content. After pulling out everything, so there are multiple defects. Now you're seeing all this sieve-like defect. Unfortunately, this is the midline where the cesarean was done, and these are all the defects all along the midline incision. I'm cutting onto the so after careful dissection, so this is a normal rectus sheath. Again, on that side also normal rectus sheath. We have to narrow this by extracorporeal multiple proline knots like this, and keep a mesh on top of it and tack them to, keeping the mesh and tacking them. Tacking again is another point. We have to tack it at least double row, or one, and again one more row of tackers, which will fix the mesh all along the abdominal wall. Next slide. So this is actually one limitation, but this is the spigeal hernia, where the defect is at the arcuate line. It may vary from 1 centimeter to 5 centimeter defect, and mostly small bowel will get into the hernia generally, like ileum. Ileum can cause subacute pain and obstruction, or chronic intestinal obstruction. Can present as a chronic intestinal obstruction. This is the portion of the hernia, that is portion of the intestine which was stuck to the. This is actually a weeks back I did the case, and as you see, this is the defect, arcuate line defect. This is the arcuate line, and the spigeline defect is on the left side. I kept a small mesh and tacked around, and after you can see the video. So you can see this is the portion of the intestine which is going up. You can see how it is getting reduced. Just a pull, it has come down. And this is the Richter's, this is called Richter's hernia. Portion of the bowel has got stuck in the spigeline defect, and it's pulled down, and by extracorporeal arts, I'm narrowing I'm narrowing these defects and tighten them so that it gets closed. And after tightening, you have to keep a small mesh. This is actually I kept proline mesh. Proline mesh are a little dangerous because the intestine may get stuck along the proline mesh. Generally, it happens for larger meshes. This actually I kept say around 7 centimeter by 7 centimeters so that I can cover 5 centimeter all around the hernial side. So the next slide. This is yesterday's case. Multiple kinking of the small bowel stuck to the previously operated. I operated this on this man 2 years back for umbilical hernia, and of course the inguinal hernia at the same time. For him, I did laparoscopic appendicectomy and these 2 hernia repairs at the same time. So he had, you can see the mesh on the top. This is actually very dangerous. This is a mesh you can see. Unless like open surgeries, this is the best surgery we can throw for the patient, because dissection is very precise and dissection is very precise and very meticulous dissection can be done. We can use this harmonic scalpel to reduce the, detach the attachments, and slowly we can dissect. There was a kink on the adherent area. So slowly all the adhesions were released from the mesh. Generally this mesh will get peritonized. In this patient, unfortunately, we didn't use the dual mesh. The want of supply or other reasons we don't know. And see, this is a proline mesh which is totally exposed earlier, and he didn't develop any complication in between. After 2 years, is presented with vomiting and abdominal distension. Then we thought it's only because of adhesions, and the same thing was there. And slowly after dissecting, you don't have to remove the mesh, because you can ask why when the patient can go in for again recurrence of these hernias. Generally, these hernias after 2 years, they'll get peritonized. These adhesions are appeared on the initial stage. That's why we are stuck here. Otherwise, this mesh is now probably peritonized. You don't have to remove the mesh to prevent adhesions nowadays, after 2 years. So you have to just tease the adhesions. You should not cut it. You should not a small bowel. You can see the hope people are seeing our video. So you can even tease and cut, because you are not supposed to cut the serosa. If you cut the serosa, I have to put a suture. There's no other go. We can push the. So this is the denuded mesh. Of course, the mesh is incorporated in the peritoneal surface. But these are all the old additions. You can see the tacker, which is fresh, 2 years back. This is absorbable tacker I used, and it will get absorbed in a year or two. So we have to cut it carefully. There is a serosa of the small intestine. While cutting, you have to stay close to the mesh. You should not cut it towards the small intestine. So everything is good. And after releasing, because in the repair, small intestinal obstruction, when we repair laparoscopically, after dividing or adhesivolysis, we have to take a bowel walk to see where is the constriction, where is the kink of the small intestine. This one also on the right hand side where I did the inguinal hernia repair. Here also it is got stuck. So probably these mesh are not peritonized in the early stage. And he presented with, so this is the right inguinal area site. And after the bowel walk, I was telling you, bowel walk, we have to see where it is kinked and where is the obstruction. We come across a small band while doing the bowel walk. Of course, there are multiple kinks because of adhesions. So that is this is collapsed ileum. This is the dilated intestine. Because of obstruction, the proximal dilatation happened. I can show you the kinked portion. So I'm doing a bowel walk to trace the small intestine all along and up to the obstruction site. This is the red area is the obstruction site. Up till here it was collapsed. This is collapsed and this intestine is enlarged. I mean obstructed, distended. This is the portion of the kink. See, this is the collapsed area. There was a band here. From here, it is dilated. This is all the dilated ileum, where you can see the obstruction. You can see the band here. Yeah. So this can be done laparoscopically, though there are limitations for younger surgeons. But by training and there was a band over here. Yes. And the band was released. You can see the inguinal mesh here nude. And the band was released. The obstruction is also released. Patient on the first post-op day, he's fine. So these are all the challenge we come across. If you think you cannot operate intestinal obstruction by laparoscopically, even today we had a surgery, and of course it's a hernia, irreducible hernia. But for reducing, it was very tough. We have to, the patient will be happy. And this is a transition zone. And just do a bowel of this area. This is the area of band. Now the gas is going through the obstruction area. Yes, you can see the band here. And this is where the kink was. It has been released, and now the patient is fine. And slow correction. So there is another inguinal hernia, which is straightforward. Slow. You have to open the peritoneum and go extraperitoneally, dissect it so that you can keep the mesh over there, create a space, go along the extraperitoneal layer space, and dissect the. This is actually epigastric hernia. The mesh is placed. This is the hernial defect where the contents were reduced. See, the content is reduced, and after reduction, the mesh is placed over there. Then the content should be removed or inverted into the abdominal cavity so that it should not go, because fat is the rider of hernia here in epigastric region. The fatty hernia of linea alba, otherwise called the epigastric hernia or fatty hernia of linea alba. Fat is the content. Bowel will not go. Patient will have pain. Again, extracorporeal narrowing of I'm removing the fat, excising the fat by harmonic. The whole fat is removed. This is in the epigastric region, so it's difficult to do dissection and any maneuvering is difficult because there's very short space to operate, not like lower abdomen surgeries. So after removing the fat, a mesh is kept. This is the defect. You can see the defect upwards, and keep a mesh over there after narrowing the. Mesh and tack it on either side. Tack once or two, maybe all around the defect after narrowing by extracorporeal narrowing of the sac. Keep a mesh over there and tack it maybe 2-3 places. Put the peritoneum back. After laying of mesh, it's very easy to put the peritoneum in space and tack it again. Almost reduce the tacking the peritoneum along with the mesh so that it can stay in place. This is the inverted portion of the hernial sac. After tacking, but one thing is, if you are keeping a mesh, rolling mesh, plain mesh, not dual mesh, you have to cover the mesh completely. That is the sac which I've reduced inside the. It is the momentum. We are seeing everything from inside, so it will be a new anatomy for us. I'm just removing the fat which I've removed from the hernial sac. Next slide. I think it's over. Oh, sorry. This one again, more the video. This is a large inguinal hernia. This is the large inguinal hernia. The speed is very low. I think in connection with this large inguinal hernia with small bowel as content. I've reduced it. After reduction, this is the reduction of intestine, that is the ileum, reducing it. After reduction, the defect was very big. So I've done a similar hernia a year back in an automat. That is nicely reduced and he's fine. This man is a VIP, celebrity. Then I did a similar repair for this and burnt my finger because the mesh I chosen was normal, regular 15 by 12 mesh, which is not enough for the defect. So he recurred and I got my fingers burnt. So you have to assess the size of the mesh. After dissection, everything went on well. Dissection and removing the, detaching the peritoneal sac from the tunica vaginalis. Everything went on well, but unfortunately on the, I think on the 15th day, the patient recurred the hernia. He's due for open repair. Preferably if it's a laparoscopic hernia repair recurrence, do open method. If it is an open method recurrence, do a laparoscopic method. That is the dictum of hernia repair nowadays. This is the that's the sac. This is a tunica vaginalis. I'm pulling the sac out of tunica vaginalis so that it will get reduced completely. I've dissected up to the iliopectineal line. Pull without any damage to the perineal sac or the blood vessels or the cord structures in men. Today's case was a young man, so he's just 24 years old. So we should be very careful not damaging the vas deferens or cord structures. So dissection must be so. We should be very careful. Push the tunica vaginalis into the inguinal canal and pull the peritoneum into the peritoneal cavity so that we are dissecting, separating the sac from the attachments. So almost separated. Now a mesh is kept. Everything went on well, but God only knows why he recurred. And attacking everything was same, done the same thing. This is probably my first inguinal hernia which recurred. He had, because unexpectedly, clinically, there was no hernia on the left side, but on laparoscopy, I found the hernia on the left side also. And same time, I reduced and repaired the hernia as well. This is an advantage in see the defect in the on the left side. This is the right hernia. This is the left side hernia. So this is the advantage of laparoscopic hernia repair. You can find out whatever the hernia is there in the abdominal cavity. So I'm dissecting onto the left side inguinal region. Found the inguinal ligament and kept a mesh. This is the inguinal canal, and this is the white thing is the inguinal ligament. Keeping a mesh and shove in a mesh there and tack it. Maybe two pins are fine. 2 tackers are fine to keep the mesh in place. Some people don't even tack it. And I tack the peritoneum on top of it. I don't suture the peritoneum. Probably want of time. So this side repair is over. So another one is bilateral. This is again not very different. You can find a lot of adhesions of momentum to the anterior abdominal wall, and this requires patience to dissect onto the adhesions, release all the adhesions, and then you dissect onto the peritoneum to find a space for the mesh. While dissecting itself, there were momentum coming out. So you have to be very careful. You can see the internal iliac vessels and inferior epigastric. All the nerves can be seen. There are a lot of critical areas and points, triangles over here. You should be very careful in dissecting during dissection. And after dissection, completely, and you can see the white thing. This is the removing, excising part of the extraperitoneal pad of fat, so that the bulge is less. Keeping a mesh, tacking it again, the repair is over. Covering the mesh with the peritoneum. So, of course, after you see your first repair, endoscopic, laparoscopic bowel surgery, you'll try to clap yourself. At the same time, fear, no, you should go sleep peacefully without any injury to the bowel post-operative. So as I told you, this children, nowadays young surgeons are doing better surgeries than the older surgeons because their ergonomics are improved by video games. Thank you for listening. These are all the small references I have taken from our Google and other textbooks for the reference purposes. Thank you very much.
Dr. Saravanan?
Yes, sir.
Only one or two questions as a physician. Any absolute contraindication for laparoscopic surgery?
Surgery or general surgery, sir? General laparoscopic surgery?
Laparoscopic surgery for hernia, any absolute contraindication?
Absolute contraindication for cesarean.
Okay. Nowadays, I have seen one or two patients with the hernia belt. How safe it is?
No, it's safe nowadays, sir, because of availability and energy sources. We can so there's no absolute contraindication unless there is factors limiting our repair. There's no absolute contraindications.
Thank you, Saravanan. God bless you.
Dr. Saravanan, I want to ask you one question. After this fan and steel for cesarean section, have you come across any hernia following fan and steel incision?
Yes, a lot of hernias which can be easily removed. There are few cases in our
on the lateral end.
Lateral end. And from obesity. 20-25 years, the patient develops a hernia all along the site. So that is also easy. I kept two meshes to cover the incision is too long. So I had to keep two meshes and tack it after extracorporeal of the corneal side.
Thank you, Dr. Saravanan. It was a picturesque presentation.
Yeah.
And I just wanted to ask you about the 70s and 80-year-old men and women who develop this inguinal hernia and femoral hernia. Would that be a contraindication, age and flaccidity of muscles?
Actually, age is one factor. Because if you do open surgeries, patient will have a lot of more bleeding and there will be a lot of pain. Elderly patients, better to have laparoscopic surgery unless they are not contraindicated by CPM. You can do it by spinal anesthesia also, or hernias. Any abdominal surgery can be done by any abdominal laparoscopic surgery can be done by spinal.
So, like inguinal hernia, if they were already had umbilical hernia, if they were already had proline mesh, do we continue with the laparoscopy method once it recurs? That's what you projected. And you said the proline mesh can be kept in situ. Over and above that, you can use the dual mesh.
Yes.
Does it work that way?
Yes. When we get a recurrence in laparoscopic proline mesh repair, we always prefer to put a dual mesh on top of it, all around, which should cover at least 5 centimeters away from the hernial orifice. So wherever the recurrence, it is not going to recur all around. So if you have a proline mesh, if the recurrence is on the left side, you cover at least 5 centimeters all around the defect, and after narrowing the neck of the hernia.
And you'll have to entirely leave out all the adhesions have to be released?
Better. Otherwise, the patient will go in for interstitial obstruction later on.
Okay. Thank you.
Thank you.
Any more questions? Thank you. No more questions. Thank you very much, sir. Mangai? Vote of thanks, Cholriya.
Unmute, Dr. Mangai. Unmute your mic.
Yourself. உங்களுக்குலாம் சத்தம் ஏதோ வருது ரொம்ப, அதனால மியூட் பண்ணி வச்சிருந்தேன்.
இப்ப பாருங்க.
அங்க அன்மியூட் பண்ணுமா?
Yes, ma'am. Am I audible?
Noise is coming.
Good evening, everyone. First of all, I want to thank our president, Dr. C.V. Natarajan, and our secretary, Dr. Shanta Narayanan, for conducting and organizing this CME. A special thanks to our IMA state president, Dr. Ramakrishnan, the chief guest, for readily accepted the invite and will be with us in spite of his busy schedule. And sincere thanks to our North Zone Vice President, Dr. Maragadamani. I wish to thank both the speakers, Dr. Vidya Narasimhan, consultant neurosurgeon, for her excellent talk on in the common neurological symptoms and brain tumor. And thanks to Dr. V. Saravanan, general and laparoscopic surgeon and CMD, Girishwari Hospital, for his wonderful talk on laparoscopic approach of hernia repairs and its limitations. It was very lively and nice. Thank you. And I wish to thank all the members of our IMA Chennai South who had attended this CME. Thank you, one and all.
Thank you.
There was a question. There was a question on the chat box.
Sundaramurthy sir.
Yes. Can you see that?
One for she answered that question by what?
The belt is not very safe, madam, in large hernias, because the large come around and get between the belt and the abdominal wall. It's not safe in large hernias. Probably the hernias will be safe. Thank you, madam. Thank you.
For Vidya, I think you have answered all these questions. I think how common tuberculoma brain presenting as brain tumor?
Ma'am, Dr. Vidya, unmute your mic.
Unmute, Vidya.
all the chat box questions were asked in person also, and I have answered them.
Right. Okay. So there is one.
Diaphragmatic hernias are not very common nowadays, ma'am. Dr. asked this question. Not very common, sir. In congenital diaphragmatic hernias only nowadays you're coming across. Last operation was an old lady with the diaphragmatic hernia with other complications. After that, there is no diaphragmatic hernia. That's all the
This
question.
hiatus hernias.
Yes, no, the hiatus hernias are very common. Even young people develop
Yes.
nowadays. And those who are with epigastric pain and
Hernia, common anemia, presentation with anemia.
and not amenable for medical treatment, always after endoscopy, we have to consider hiatus hernias. Young children, they develop
Newborn also, sir.
yes. No other question, I think.
Thank you very much.
Thank you.
Thank you.
Thank you all for your active participation. Thank you, Vidya. Thank you, Dr. Saravanan.
Thank you, madam.
Thanks, Dr. Ramanujam. Vidya, Dr. Ramanujam who asked you about questions. He's a neurophysician, senior neuro consultant in VHS Hospital. Our introduce Manikalavar. He didn't introduce himself. First, I was telling that he's a senior most consultant in the VHS.
Thank you.
Thank you, sir. Thank you for your interaction. Pleasure to interact.
Always active.
இப்பவும் படிச்சுட்டே இருக்காரு. இப்பவும் நான் ஏதோ டிகிரி வாங்கிட்டே இருக்காரு அவர். Thank you all.
Thank you so much.
Thank you very much. Our next CME is papyrus to pump, that is on the 28th of this month. In between ஏதாவது வந்ததுன்னா சொல்றேன்.
Thank you, Anpa.
Thanks, Kanna. Thank you so much.
Thank you.